Alright, this is it. This is the last one for this chapter, folks. So this is going to be talking about the four conditions you see here, and four main conditions, because we divide these conditions up further into compensated or uncompensated, etc. So the four main conditions we have two acidotic conditions. We have respiratory acidosis and metabolic acidosis. We also have respiratory alkalosis and metabolic alkalosis. The terms acidosis and alkalosis mean, well, acidosis means that you are less than 7.35 for your pH. That's what that means. All right. And the alkalosis means that you are greater than 7.45 for your pH. Now, the reality is you could actually have a condition that's compensated for and your pH be normal, but it throws off some other measurements in your blood, and you can see that something's abnormal, and we can say fully compensated respiratory acidosis or fully compensated metabolic acidosis, and vice versa. So, and the same thing for the respiratory part. So sometimes you actually will have a normal pH and your CO2 will be way off, or your anion gap will be way off, or something like that, and you can see that it's because of a fully compensated condition. Now, that's not bad to be fully compensated, but ultimately you do want to correct the problem that's causing you to be acidotic or alkalotic. You have to correct that, but it's good if you can compensate, because if you can't compensate, now you're going down the pathway to death if you can't compensate. So we got these four conditions here. You can see the pHs. Please memorize the normal pH. Now, please do not memorize these bicarb values and PCO2 values. I will give them to you. I will give you the normal values. All right. So I'll show you this chart at the end of this mini lecture, because the rest of this mini lecture is actually explaining what this chart shows you, explaining why the bicarb goes up or why the bicarb goes down, etc., etc. So this is just starting out. All right. Now, what kind of acidosis response is caused by the addition of? Okay, so this is metabolic acidosis. How do I know this is metabolic acidosis? Because it says the response to acidosis caused by the addition of protons. So metabolically, we've added protons. I don't know if that's a fixed acid like sulfuric acid or phosphoric acid, or if it's an organic acid like keto acid or lactic acid. I don't know which one it is, but I know I've added protons. So what happens when I have this metabolic acidosis? Adding the protons. Well, what happens is my respiratory system compensates. Okay, so just follow it. Lactic acid added the proton. Here's the proton from lactic acid. The proton combines with the bicarb in the blood and becomes carbonic acid. That disassociates into CO2 and water, and I breathe out the CO2. So what was my compensation for metabolic acidosis? It was hyperventilation, or and actually it might not even have had to have been really hyperventilation, but just a slight increase in respiratory rate. So I'll write hyperventilation, but realize I might not have had to increase my ventilation rate to the point that it was called hyperventilation. It just could have been a slight increase. All right, so that's one thing that happens, is I respond to these acids by hyperventilating. Okay, now what else can I do? Well, what else can I do is I can secrete the protons into my renal filtrate and urinate them out. So I have a respiratory response to acidosis and I have a renal response to acidosis. I have both. Hopefully they're both functioning fine. Hopefully they're good. Now, how do I know that this is metabolic acidosis? And the answer is this. Well, first of all, it says right here, addition of protons. It didn't really say where they're coming from. But I also know something else, that respiratory acidosis is by increasing CO2, by not breathing well. Respiratory acidosis is when you can't breathe well at all. And CO2 goes up, and that shifts the equilibrium of this reaction to the carbonic acid, and that's causing the acidosis. But in this image right here, my lungs are working fine. It's telling me I'm breathing fine. So this had to be metabolic acidosis. And in this metabolic acidosis, I respond with my respiratory system, and I respond with my renal system, and I got rid of it. I also buffered it. I have some buffering going on here. So that's my response to acidosis. Here's my response to alkalosis. Now, it's saying the removal of hydrogen ions, and I mean, what the heck's going on there? Well, it could be, vomiting, could be diarrhea. No, actually not diarrhea. It could be vomiting because you made all that hydrochloric acid and you just vomited it. You vomited that hydrochloric acid out. It could be. I'm trying to pick. I mean, it could be a lot of things, but I'm trying to pick something where nothing's wrong with the kidney and nothing's wrong with the lungs. That's what I'm trying to pick. But you removed hydrogen ions for some reason. Oh, you inject. Oh, too much antacid. That's another one. You ate too much. What are those antacids called? They're called Tums. Too much Tums. All right. So too many antacids. So you removed a whole bunch of hydrogen ions. What do we do? Well, first of all, our respiratory system hypoventilates. We slow our breathing down. If we hypoventilate, we retain CO2 in our blood. It drives the equilibrium of this reaction towards carbonic acid and towards the proton. Good, because I removed too many of them. What else do? We quit secreting protons into our urine. We quit doing that. And we do secrete the bicarb into our urine. So bicarb is the conjugate base of carbonic acid. So we increase the secretion of bicarb and we decrease the secretion of protons in our urine. And this corrects our alkalosis. So we also have a respiratory and a renal response to alkalosis. We conserve or retain the protons. That means less in the urine. So you got to be careful here. Less protons in urine, therefore, a triangle of dots means therefore. More protons in blood. Be careful of what compartment you're in. So there's the response to alkalosis. This is a collage showing you that under normal conditions, both my respiratory mechanisms and my renal mechanisms respond to both acidosis and alkalosis just fine. All right, so this is another way of looking at it, but this is respiratory acidosis. So I know up here it says and alkalosis, but I think I'm doing this respiratory acidosis first. Yep. So I'm just doing respiratory acidosis first. So how do I know it's respiratory acidosis? Because my PCO2 increased. My PCO2 increased because I'm not breathing well, or something's going on in my PCO2 increase. I'm not either temporarily or acutely or chronically not breathing well. All right. I mean, it could be as simple as you're holding your breath, but it could also be a chronic condition of emphysema or chronic obstructive pulmonary disease. So I'm not breathing well. I'm not blowing off the CO2. The PCO2 in my blood goes up. My blood pH goes down. That's acidic. What do? Well, I have receptors. I have receptors in my bloodstream, and I have receptors in my brain that detect this low pH, and they try to increase the respiratory rate. Now, if this is possible, I will hyperventilate and blow off that CO2 and fix it. But this is respiratory acidosis, and unless it's acute respiratory acidosis, it might not be possible to fix my breathing. I mean, you really can't fix emphysema this quick anyway. So if that's not possible, my renal compensation has to occur, and I increase the proton secretion and the bicarb retention, and I buffer that acid. All right, and then I decrease, and if the breathing is possible, I decrease my PCO2, but if the breathing compensation is not possible, I decrease my protons and increase my bicarbs through my kidneys, and I restore my pH to normal. All right. Okay, now remember, this hypoventilation that started the whole thing might be acute or chronic. If it's acute, I might be able to respiratorily compensate. But if it's chronic, like COPD, then I have to renally compensate because I'm not able to increase my ventilation. All right, this is respiratory alkalosis. All right. So this is when I blow off too much CO2, hyperventilate. I'm hyperventilating. I'm blowing off too much CO2. The reason I'll tell you why they make you put your face in a bag and rebreathe when you have nervous hyperventilation or anxiety hyperventilation. But let's just go through this first. So I'm hyperventilating. I have decreased PCO2 in my blood because I'm blowing it all off. That makes an increase in pH. All right, and that's alkalosis. Well, if I can respiratorily compensate, I do, and I decrease my respiratory rate. I just decrease the rate. I go back to eupnea. So let me just tell you some words. Eupnea is normal breathing. Normal breathing. Dyspnea is difficulty breathing. Hyperpnea, I think I spelled it right. Hyperpnea is fast breathing. I don't know if there's a hypopnea. There must be. There must be. And then apnea is not breathing. Apnea is no breathing. So those are some words that you need to know. So in this case, if I could respiratorily compensate, I would come back to eupnea or decrease my hyperventilation back to a normal breathing rate. Renally, I would compensate by retaining protons and secreting bicarb, and this would bring my alkalosis back to normal. All right. All right, so that's the response to respiratory alkalosis. This is the collage showing you the response to acidosis and the response to alkalosis. All right, let's talk about the response to metabolic acidosis. My response to metabolic acidosis is I increase my breathing rate. So my arterial and cerebral spinal fluid chemoreceptors detect the high protons. High protons equals low pH, remember. So my arterial, they're in my carotid sinuses. These arterial chemoreceptors are in my carotid sinuses. I know it doesn't tell you that, but that's where they are. They detect the high protons or low pH, and they send a signal to the diaphragm. They say increase respiratory rate. You blow off the CO2. You decrease CO2. That returns your pH to normal. Additionally, my kidneys will compensate. I'll secrete more protons, and I'll retain more bicarb, and that'll bring my pH back to normal. So that's my responses to metabolic acidosis. Here's my responses to metabolic acidosis. Why is it metabolic acidosis again? Oh, I get it. This was my response to metabolic acidosis because I increased protons. That's like one of the fixed acids donating protons, or one of the organic acids like lactic acid or keto acids donating protons. But this next metabolic acidosis is different. My blood pH decreases because I don't have any bicarb to buffer. I'm lacking bicarb. Remember, bicarb is one of these major buffer systems. So now I have metabolic acidosis because I have a depletion of bicarbonate reserve. All right. How do I compensate for this? Well, first of all, my carotid sinuses my carotid sinuses have pH receptors that detect that, and they say to you, breathe faster, increase respiratory rate. That decreases my PCO2 and brings my pH back to normal. But that doesn't correct my bicarb problem. That only starts to correct my pH problem. I still have a bicarb problem. It's too little. Don't worry. Kidneys do this. Kidneys secrete more protons, and they retain all the bicarb and bring my bicarb back to normal. That replenishes my bicarb buffer system, my carbonic acid bicarb buffer system. And it also helps to bring my pH back to normal, and I come back to normal pH. So, pretty important here that I can be metabolic acidosis for two different reasons. And I'm sorry I had to figure it out while I was talking to you, but that's the answers right there. All right, what about metabolic alkalosis? Well, I have increased bicarb for some reason. So I gained the bicarb for some reason, or I lost the protons for some reason. You know, whatever's going on here, I could have gained the bicarb or lost the protons. Well, here's what happens. I slow down my respiration rate. My my carotid sinus has receptors that detect pH. When the pH is too high, I slow down my respiratory rate. That retains CO2 and I increase my CO2, and that brings my pH back to normal. What do my kidneys do? No problem. They retain the protons. Yep, we're alkalosis. They retain the protons and they urinate out the bicarb. They secrete the bicarb. I'm alkalosis, so that's a good thing. I'm urinating out base and I'm retaining acid. It brings my pH back to normal. All right, I hope you're getting sick of this because it's the same thing over and over and over again. And that means if you're getting sick of it, you understand it. If you're not getting sick of it yet because you don't understand it yet, replay this part of the video. All right, so this is the collage showing you the responses to metabolic acidosis and metabolic alkalosis. No, actually, these are just both metabolic acidosis. All right, I do have to talk about different phases of these acid-base imbalances or disturbances. Because I have an acute phase, and this is when the pH moves out of normal range rapidly, but it can be potentially be brought back into range through these compensation mechanisms we just talked about. All right, the respiratory and the renal compensatory mechanisms. Then I have this compensated phase where my pH can come back to normal. It actually can come back to normal, but you can look at an arterial blood gas, ABG, arterial blood gas, and you can tell, even though the pH is normal, that something bad's going on and they're actually compensated. By the way, arterial blood gases are usually drawn from the radial artery. They palpate the radial artery. It's a syringe lined with heparin so the blood doesn't clot. They push that needle of the syringe slowly into your radial artery at a 90-degree angle or vertically. And it's not like normal venipuncture or phlebotomy where you put the needle in fast, suck a bunch of blood out through these vacutainers and pull the needle out. This goes in slowly, takes time. They send the arterial blood gas to the lab for analysis on ice. Arterial blood gases are no picnic, they're painful. But that's how we measure these blood gases like CO2 and oxygen and pH and things like that. All right. So we could have a compensated phase where your pH really could come back into normal range. But you still have to fix the underlying problem because your compensatory mechanisms might fail and bad pHs can kill you. The lowest pH I ever saw in the lab, I'm trying to think back, was probably like a 7.19 or a 7.18, and that's pretty low. I know they've been lower in the lab, but that's the lowest I've ever seen. Now look at this is a bad condition right here. Because typically speaking, if I have respiratory alkalosis or respiratory acidosis, and I can't compensate through the respiratory means, I compensate renally. Or if I have metabolic acidosis or metabolic alkalosis and something's wrong with my kidneys and I can't compensate renally, I compensate through my respiratory system. So you can see that I have these systems that can compensate for each other. But this disease is combined respiratory and metabolic acidosis. That's not good. My lungs can't compensate for me and my kidneys can't compensate for me. Now, look at my lungs aren't compensating. They can't breathe faster. My respiratory system can't breathe faster and blow off CO2. They can't breathe faster, which leads to low oxygen, which generates lactic acid, which adds to the acidosis. So this is really a bad condition, combined respiratory and metabolic acidosis, because it's almost like this positive feedback loop that occurs. And what the doctors have to do is they have to buffer the blood and they have to fix the condition. All right. So this is like a flow chart of how to think when you're helping the doctor diagnose these conditions. First of all, you always look at the pH. All right. If the pH is less than 7.35, that's definitely acidosis. All right. But then you have to ask yourself, is my PCO2 normal or decreased? Because if my PCO2 is normal or decreased, then I'm metabolic acidosis. And think about that. Why would my PCO2 be decreased if I have metabolic acidosis? Because I'm hyperventilating to compensate. So if my PCO2 is normal or decreased, I have metabolic acidosis. Because if I breathe faster, I blow off CO2 and my CO2 goes down. My PCO2 goes down. My lungs are obviously working fine because I'm breathing faster. So it must be metabolic acidosis. Now, if my PCO2 is increased, well, that means I'm not breathing well. And if I'm not breathing well, then that's respiratory acidosis. All right, let's go down the left-hand side first. Let's say you are metabolic acidosis. All right, if it's acute metabolic acidosis, your PCO2 is normal because you haven't started compensating yet. All right, but if your PCO2 is decreased, then it's compensated metabolic acidosis, and you're starting to compensate, and you actually might compensate to the point of bringing your pH back to normal. In fact, diabetics that chronically go through diabetic ketoacidosis have what we call Kussmaul respirations. Kussmaul, Kussmaul respirations, spelled for you right there. And what they do is they breathe more deeply and rapidly to adjust for their ketoacidosis. And they actually have this Kussmaul respirations. All right. Now, that's the PCO2. We also want to check the anion gap because we don't know if it's organic acids or fixed acids. We don't check this anion gap. Now, what is the anion gap? Here's what it is. My major extracellular cation, sodium, is measured. All right. And I subtract from that the two anions, the two major anions. And that's bicarb plus chloride. I add those two anions together and I subtract that from sodium. I always get a gap. I always get a number that's left over. It's never zero. And by the way, some people calculate this as potassium plus sodium, but you still get a gap. And let's say the gap is 8. Let's say you get 8. All right. So 142. This would be, say, 110. And then this would be 120. Yeah, that's about 8. So if this was 4, because normal potassium is 3.5 to 5, if that was 4, and this was 140, that's 144 minus, let's say the chloride was 110, and this was, what, 25? That'd be 130. Let's say this was 28. 28 is normal for that. 138. 144 minus 138. That's 6. Let's say my anion gap is 6. All right. My anion gap is 144 minus 138. It's 6. All right. Now, let me explain this to you. That would be around in the normal range of an anion gap. If I add keto acids like acetoacetic acid or beta hydroxybutyric acid or acetone, if I add keto acids, their conjugate bases are anions. I'm adding anions to this, but I'm not measuring them. I am not measuring them. All right. What this does is makes my anion gap go up, because if I add these keto acids, my bicarb goes down. Now my bicarb is going to be a 10, say. All right. So now it's 144 minus 120 rather than 138. And 144 minus 120 is 24. My anion gap just went way up to 24. It went from 6 to 24. I have an increased anion gap. Now that happened because I have these acids that are in my body. So if I have an increased anion gap, it's due to lactic acidosis or ketoacidosis. Ketoacidosis. However, if my anion gap is normal, it's not because I've added any organic acids to my blood. It's probably due to something like loss of bicarb. Well, how do I lose bicarb? Diarrhea. That's one way to have this metabolic acidosis, would be diarrhea. All right, so that's the anion gap, and that's how I would help the doctor diagnose this. All right, now Let me erase all of that and go down the other pathway. By the way, arterial blood gas analysis, looking at them is really cool. But as usual, it's never textbook. You can hardly ever get a patient to be textbook, which is kind of frustrating sometimes. All right, let's go down this respiratory acidosis. First of all, I have a high PCO2. That's why I knew it was respiratory acidosis. I'm not breathing well. I'm hypoventilating for whatever reason, COPD, emphysema, whatever it is. Okay, and I'm not breathing well. That retains the CO2. That leads to acidosis. Okay, now, how do I know if I'm acute or chronic? I look at my bicarb level. All right. If I'm acute, my bicarb is still normal. If I'm acute, my bicarb is still normal. But if I'm chronic and I'm trying to compensate, then my bicarb is increased. All right. Now this is acidosis. So that makes sense that and it's respiratory acidosis. So how do I adjust for that? My kidneys retain bicarb and they urinate out protons. So if I'm trying to compensate, my kidneys are retaining the bicarb, and that goes up in my blood. All right. So let's go down this uncompensated respiratory acidosis. What are examples of compensated respiratory acidosis? Anything that is bad breathing, emphysema, asthma, COPD, anything that's chronically bad breathing, and it has to be chronically bad breathing. But what if your bicarb's normal? Well, this is an acute respiratory acidosis, and it's an acute bad breathing, like respiratory failure for some reason, a pneumothorax, that's a collapsed lung. So this is an acute case of it, not chronic. All right, so that's how I help the doctor diagnose these acidotic conditions. If you don't understand anion gap, please ask me to do it in lab. All right, these are how we help the doctor look at alkalotic conditions. So first of all, I check the pH. If the pH is greater than 7.45, I have alkalosis. Now I check the PCO2. Because if the PCO2 is increased, then I have metabolic alkalosis. Why would the PCO2 be increased with metabolic alkalosis? Because my lungs are working fine, and I'm trying to compensate for that, and I'm hypoventilating. So my PCO2 is increased because I'm hypoventilating. All right. So the fact that I can actually hypoventilate, control my breathing, means there's nothing wrong with my lungs. So it must be metabolic alkalosis. All right. However, if the PCO2 is decreased, then that's the very thing causing my alkalosis, and that's respiratory alkalosis. And I am hyperventilating. Now, this is usually due to anxiety disorders. Ventilating. Hyperventilating. I can't spell, but there's hyperventilating. Primary cause is hyperventilation. This can be due to anxiety disorders. You hyperventilate when you're anxious. They have you rebreathe into a bag because you're rebreathing what you're blowing out, which is CO2. And the problem is your CO2 is decreased in your blood. So if I breathe into a bag and I inhale, I'm inhaling the very CO2 I just breathed out. Well, that goes back into my bloodstream, which is good because my blood has too little CO2. That's why you breathe into a bag. All right. You can see panic attacks right there. Okay, but we don't know that if it's acute respiratory alkalosis or chronic respiratory alkalosis. We have no idea. Check the bicarb. All right. With acute respiratory alkalosis, my bicarb is normal. And it says here it might be slightly decreased, but it's basically normal. My bicarb is normal. All right. What is this due to? Panic attacks. All right. That's my hyperventilation. I'm acutely breathing fast because I think the plane's going to crash. But if it's chronic, over here, I check my bicarb, and my bicarb is significantly decreased. See over here, it says slight decrease. So this is significantly decreased. And I check the bicarb for that. It's significantly decreased. And this is not the acute hyperventilation. This is hyperventilation for another reason, like anemia. Why would anemia make me hyperventilate? Well, think about it. The blood is only there to carry oxygen for you. you're anemic. You either don't have enough red blood cells, or you don't have enough hemoglobin, or you don't have enough iron. All of that means you can't carry oxygen. Well, your body doesn't really know all of these things. It just breathes faster to try to get you to carry more oxygen. It hyperventilates you to try to get you to carry more oxygen. And that leads to this chronic respiratory alkalosis. And of course, CNS damage can affect you because you have these circuits, like you have this carotid sinus that has pH receptors that go through the central nervous system. In your central nervous system, you have receptors that detect the pH of cerebral spinal fluid, and they affect your breathing as well. So CNS damage can lead to hyperventilation. All right, that's the two pathways for metabolic alkalosis and respiratory alkalosis. This is the collage. This is showing you some anion gaps. It's showing you patient 1, 2, 3, 4. So anion gaps. See these real high anion gaps? This is definitely like a lactic acidosis or a ketoacidosis. Is it acidotic? You bet. 7.2. You got it. Now this patient, real low pH, the anion gap isn't significantly increased. All right. So that's probably not ketoacidosis. That's probably another acidosis right there. And these two patients are alkalosis, by the way. So they're not. So we don't have to worry about the anion gap and the alkalosis. All right. What about fluid and electrolyte balance in the young and the old? All right. The fetus. The fetus does have the carbonic acid buffer system available to them, but remember one thing: they're not exhaling. They're actually not inhaling either. So the fetus has to rely on the mom to get rid of the protons. But that doesn't mean the carbonic anhydrase is not there. It is. So what the fetus does is produces all this CO2 because H2O plus CO2 gives you carbonic acid. So, that whole reaction occurs. The fetus gives CO2 to the mom, and the mom gets rid of the CO2. So in this way, the mom can get rid of acids for the fetus. The fetus does have buffer systems in there, but the fetus is not breathing, remember. And the fetus is actually not urinating either, except for, you've probably heard of this. Towards the end of pregnancy, sometimes the fetus might urinate just a little bit in the amniotic fluid, and that's not abnormal. But it's not like the fetus grows for 9 months urinating inside the uterus. It doesn't do that. So it's all up to the mom to adjust the baby's pH. And typically speaking, the mom does it quite well. The electrolyte balance in babies, newborns. The biggest thing with newborns is they can't withstand dehydration. They can't withstand it. And when you dehydrate the baby and their electrolyte balance goes awry, it could be deadly for them. The very young and the very old don't withstand dehydration well at all. And just remember about the calcium and the potassium. Both high and low calcium and high and low potassium cause heart problems. All right. So I just erased the K because it didn't look like a K to me. So calcium and potassium, high and low, both cause heart problems of both of these cations. So the dehydration that can't be tolerated also leads to either hypercalcemia or hyperkalemia, which leads to heart problems. What about the elderly? Well, we already told you this, that by the time you're elderly, like about 55. I'm kidding. I'm sitting across from my office mate who is probably right around that. So by the time you're elderly, you have lost some nephrons. You lose nephrons just because they're damaged in different times of your life. Running a marathon, you probably damaged some nephrons because you had high blood pressure for a while. You don't even see a difference in your urinalysis until you've lost at least 50% of your nephrons. But by the time you're elderly, you've lost some nephrons, so your kidneys aren't functioning as well. So we can't really get rid of these toxins and drugs as quickly as we once could, because remember, the toxins and drugs are eliminated in the urine. We also have decreased water content in our body. Our connective tissue loses hyaluronic acid. Hyaluronic acid keeps water in the connective tissue. And by the way, that's one of the reasons why you wrinkle when you get older, because your connective tissue has less hyaluronic acid in it. And you lose the water, so your connective tissue wrinkles. Because when it's filled with water, you have this nice cherub-looking face. a nice round cherub face, but when you lose the hyaluronic acid, it wrinkles. So we have reduced kidney function, we have reduced water content. Because we have reduced kidney function, we can't regulate pH as well. All right. So we have all this going on. In addition, I told you about insensible sweat. It's sweat you don't notice. It's not like your armpits get a ring of sweat on them. Well, as your skin becomes thinner as you get elderly, your insensible sweat increases. Now you're losing more water, and you might not be able to do your fluid balance as well. All right, so that's the things that happen when you get older. We already talked about this one. Your ADH receptors decrease. You're less sensitive to ADH. So that's the antidiuretic hormone. So you're less sensitive to ADH. You have a hard time conserving water. All right. What about your lungs? Well, your lungs do change. Your vital capacity changes. And I don't want to go through this whole thing that we did in 203. But remember what your vital capacity is you have this tidal volume. That is your normal breath. It's about 500 mils. And then you have this inspiratory reserve. Beyond the tidal volume, you can inhale some more. And then you have this expiratory reserve. Beyond the tidal volume, you can inhale, you can exhale some more, so you can inhale some more, and you can exhale some more. Your vital capacity is from there to there. So it's basically your functional lung capacity. I mean, you do have this residual volume, this dead volume. That's not part of vital capacity. But the vital capacity is your functional lung volume. Your deepest breath you could take in. That's what your vital capacity is. All right. You have a reduction in that. So if you're trying to forcefully inhale, you don't have the same capacity to do that. And that therefore you don't have the same capacity to compensate for metabolic acidosis and breathe all that CO2 out. So you have an increased risk of respiratory acidosis. All right, so that's some things that happen as you get older. All right, folks, reproductive system is next. And I know the syllabus says I'm going to do chapter 29, but I'm not. It's not cheating you. We don't do chapter 29 in the normal face-to-face classes. We do not. Dr. Vincent doesn't do chapter 29 and face-to-face 204, and I don't do chapter 29 and face-to-face 204. We don't have time. I was going to impose it upon you just because it's really your time listening to these annotated, narrated lectures. It's not mine. But I am feeling summer coming on, and I decided to just stop with reproductive chapter like we normally do. So next chapter is chapter 28, reproductive chapter. That's the last chapter. So I'll see you, not really see you literally, but you will listen to me talk about reproduction shortly. Talk to you soon.